أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. Diagnosis of acute pulmonary embolism. The diagnosis of a pulmonary embolism can be difficult and involves a clinical assessment of the probability, and this takes risk factors, clinical presentation, and clinical signs into account. Investigation performed may add weight to the clinical detection rather than being standalone diagnostic tests. Therefore, the estimation of the pretest clinical probability of DVT and PE is of vital importance in interpreting the results of the tests performed. Pretest clinical probability scoring systems include Wells score for DVT and Wells score for PE. I'll mention now the Wells score of PE. Every item of the following will take a specific score. The clinical signs and symptoms of DVT will take 3. An alternative diagnosis is less likely than pulmonary embolism will take 3 score. Heart rate more than 100 beat per minute will take 1.5. Immobilization for more than 3 days or surgery in the previous 4 weeks will take 1.5. Previous DVT or PE will take 1.5. Hemoptysis will take 1. Malignancy will take 1. So the likelihood of pulmonary embolism will be likely if the score of the total score more than 4 points, and the PE unlikely if the score below or equal to 4 points. Investigations in pulmonary embolism. The ECG, it is non-specific test. And non-specific changes are frequent in ECG, most commonly sinus tachycardia, atrial fibrillation, right bundle branch block, anterior T-wave inversion, indicating right ventricle strain are common, and S1 Q3 T3 pattern is uncommon. A chest radiograph, a good quality departmental chest X-ray is required. No specific features are characteristic of pulmonary embolism, but it may reveal another pathology. Small effusions are present in 40%, 80% are exudates, and 20% are exudates. Focal infiltrates, segmental collapse, and a raised hemidiaphragm can also occur. ABG, arterial blood gas may be normal, especially in the young and healthy, but hypoxia and hypocapnia due to hyperventilation with increased AA gradient are more common. The D-dimer is very important. D-dimer has an important role in diagnosing and excluding pulmonary embolism and should only be used with a pretest clinical probability assessment following careful clinical evaluation by an experienced clinician. D-dimers are sensitive for DVT and thromboembolism, but not specific. They are rarely in the normal range in cases of acute thromboembolism, but are not a valid screening test for PE alone. The dimers are generated as a result of fibrinolysis, which occurs in young which occurs in many clinical situations, including sepsis, post-surgery, pneumonia, neoplasia, inflammatory disease, pregnancy, and advanced age. And some labs will quote at age multiplied by 10 at the upper limit, normal, aged over 55. Only a normal result which virtually excludes PE is of clinical value. Abnormal result, however high, does not necessarily imply a significantly increased probability of PE. The sensitivity ranges from 87% to 99%, depending on the assay rules used. They should be known before the incorporating into the diagnostic algorithm. The BNB levels, which is brain natriuretic peptide levels in acute PE, reflect severity of right ventricle strain and hemodynamic compromise, providing additional prognostic information to that of echo. And elevated cardiac troponin levels are associated with worse short-term prognosis in acute PE. Heart-type fatty acid binding protein and early markers of myocardial injury is reported to be superior to troponin or myoglobin measurements for risk stratification of PE on admission. There are currently no universally accepted criteria for measurements of myocardial injury in acute PE. CT pulmonary angiogram is the gold standard investigation and is recommended as the initial imaging technique in suspected non-massive PE. It has sensitivity more than 90% and maybe enable an alternative diagnosis to made if PE is excluded. Advances in imaging mean that 16 slice multi-detector RAW scanner can image the entire chest with resolution approaching 1 millimeter, requiring a breath hold of below 10 seconds. Emboli can be detected in 6 order pulmonary vessels, which are small that their clinical relevance is uncertain. CTBA should be performed within 1 hour in suspected massive PE and within 24 hours of suspected non-massive PE. The sensitivity and specificity of CT pulmonary angiogram depends on the location of the emboli, with lower sensitivity for clot confined to the segmental or subsegmental pulmonary vessels compared with more central clot. CTBA needs specialist reporting, and in those with a high clinical probability but negative CTBA, the options are PE has been excluded, so we'll stop anticoagulant or perform further imaging such as leg ultrasound, conventional pulmonary angiogram, venous phase CT to exclude the leg. Other imaging techniques: leg ultrasound. Around 70% of patients with proven pulmonary embolism have a proximal DVT, hence leg imaging can be used as an alternative to lung imaging in those with clinical DVT. Conventional pulmonary angiogram is available in a few specialist centers only where catheter fragmentation of large clots may be of therapeutic benefit, and CT venography is an emerging area. It can be combined with CTBA to the image the pelvic leg veins simultaneously. Echo diagnostic in submassive and massive PE and transthoracic ultrasound is used uncommonly, may show peripheral infarcts with peripheral pulmonary embolism. That's all, and thank you.